Thanks, Ted. Thanks, Amir. I appreciate the opportunity to be here and try to share some wisdom to you. I'm not sure I'm the one to tell you how not to have disasters, though, so we'll see. Fair enough. So no disclosures. All right. So plain film evaluation of the acetab to me is, my residents run to CTs. Patient sneezes in the ER, we get a CT. So I think it's important to learn how to read the plain films. And you do that for the young people, you do that for the older people. CTs can be important, maybe not as important as with the pelvis, as Kyle points out. But you need to learn to look at the Jude views. And you need to do this because when you go to the operating room, you don't have a CT. You have a fluoroscope. And if you can't read plain films, you're useless in a fluoroscope. So you got to know how to do this, so that's important. Fair enough, and CT can be helpful. We need to find the classification to figure out which way we want to operate the pelvis for the acetabular fracture, and that's important. In geriatric fractures, which are increasingly common, as we know, it's the anterior moides, the anterior column or anterior wall with the posterior transverse, or the both columns seem to be the more common patterns we'll see in this population, so that's important to realize. In terms of outcomes, if we look at the overall mortality rate, kind of similar to a hip fracture in an older population, the mortality is really fairly good compared to femoral neck fractures and intertroches. The delayed fixation, if we want to optimize our patients, doesn't seem to be a problem. So you're urgent for long bone fractures, but not so much for articular fractures. And the geriatric fracture assessment can be important for your older patients. So we want to think about the criteria for non-operative care, and remember it's the relationship of the superior acetabulum and the femoral head out of traction. If that relationship is maintained and the joint's stable, sometimes you need to do an exam under anesthesia to determine that, but if the joint's stable, then they can be treated non-operatively. So if we do non-operative treatment, generally if it's non-displaced, minimally displaced, or stable, and the patient can be mobilized and they're comfortable, that's fine. If they're not able to mobilize them, it's probably not going to be a very good strategy for that patient. So in terms of operative care, you can oftentimes, and what we go for, of course, is to restore the joint surgically and then fix it stably. Sometimes we end up with arthroplasty as a secondary reconstruction. But in general, these days, like when I started, the idea of you'd put everything together and there were some joints that you just couldn't hold, and trying to do this actively knowing that the joint's not going to stay, that's not really a good option, and I would not recommend that today. So things that are relative contraindications for fixation, relative that is. So posterior wall morphology, Andy's going to talk about this in a minute, so I won't spend a lot of time on it. Impaction of the superior acetabulum or injury to the femoral head. Dana Mears used to say if you have more than a third of the femoral head involved, it's not reconstructible, so just do a total joint. And then impaction of the superior acetabulum. And I'll show you a case where this becomes important, but it's the idea that particularly in the older patient, you have impacted cancellous bone. So if you reduce it, there's a big void behind that articular surface, and it's often hard to hold the reduction, even though you can get it reduced surgically. So survivorship of acetabular fractures after fixation. This is MATA's data, 20-year outcomes. Basically showing if you can get the joint reduced, you can have a pretty good outcome regardless of the age. So that's important to understand. And the same thing we found in the German trauma registry. So just a few cases to walk through this. So this is a case of a fellow who was 66 at the time of his injury. He was riding a bike. He falls, and the surgeon says, well, it's displaced. You're going to need a joint anyway, so just let it heal and whatever. So he shows up in my clinic a few weeks later and says, can you help me? Because this is not comfortable. And so this is his x-ray, and those of you who are in the labs, we'll go over this case in a little more detail tomorrow. But basically, you can see the femoral head's displaced, and it looks like there's potentially some superior impaction, so we're concerned about that as we look through these images. But when you look in detail, first off, it's got a sagittal plane, which tells us it's a transverse component to the fracture. You can see that on the CT. But then secondly, as you look at the images a little more constructively, what you're seeing is that his superior joint is really two big pieces that's displaced. It's not so much impacted as it is two big pieces. So this is a potentially fixable fracture. From a classification point of view, if you're an electronel advocate, this is really a transverse fracture with an anterior wall. So you could argue, you could call it a T, you could call it an anterior wall with a posterior transverse, but at any rate, it is what it is. His displacement was more anterior, so I elected to treat this from the front. In my case, in ilioinguinal, I think the younger guys would do a stoppa, We're able to get a reasonable reduction for this fella at 66. This is a 2-year outcome. That's 9-year outcome. So he's done pretty well over the years. So I think there's a reason to think about fixing those. Showing this case in particular because I've been asked to talk about how to prevent disasters. This is a very complicated posterior transverse with posterior wall. And the thing that makes it particularly complicated is that the greater sciatic notch is a free piece. And that's hard to pick up here on this, but it's particularly important to recognize. So when you look at the articular pattern, one of the things that we want to look at is this little piece back here in the posterior wall, because the reason that's so important is normally when you do a Coker and you're looking at the contour of the greater sciatic notch, you use that contour to reduce the joint indirectly. So when it's a free piece, you have to look in the joint to now reduce your transverse component before you can do the wall. And so then it becomes a choice of, well, how am I going to do that? And so when I was starting, people would have said, do an extended iliofemoral, do a big extensile lateral, because that's how you get in the joint. But today you can do a trochanteric osteotomy and do a digastric flip and sublux the head and get a sense of what you're doing. So this is an example of a case done that way with a Coker Langet back with a osteotomy with a reasonable outcome for this guy. But it's a complicated patient, but it could be a problem if you don't recognize that factor about the fracture. So this is a long-term case. Years ago, when I first started my practice in Sacramento, the healthcare organizations own hospitals. So this is a guy who went to a Kaiser hospital, actually a Sutter hospital, and then came back to UC Davis. This was his only injury film. This is his post-op film. I'm taking care of the guy now. He's like 3 days post-op, and this is what they sent back. And so we look at his films, we get his CT, and here's his articular reduction, and we're saying, oh, that's a pretty good-sized gap. So I had to have a conversation with this relatively young fellow about, do I actually take him back and redo somebody else's work? And so it's a hard conversation to have, but I think at the end of the day, it was probably worth doing for him. We were able to get an anatomic reduction for him because it was relatively early, but again, a way to avoid a disaster long-term for this patient. And then finally, a fourth example, just quickly, a 65-year-old with very complex transverse posterior wall. This is her good leg. The other leg has a subtroch fracture and an open tibia and pilons and all kinds of stuff. And so basically the bottom line is she needs a good joint to stand on. So because her left leg, even though it's broken, is a good leg, we're going to treat it with an acute arthroplasty because of her age and the comminution of her posterior wall, as you can see here. So ultimately, there it is. That's what it looked like. It was a mess. So fair enough. So it's a relative indication for acute fixation. Of course, you get the head out of the way. You can see pretty good to put your fixation in. That's easy. So you can go ahead and get your screws in and hold things together, put your cup in, and you can end up with a reasonable outcome. So I think the best way to summarize it is this, is in your own mind, looking at the fracture, is the fracture fixable? Can it be surgically reduced and stabilized? And if yes, can you fix it? And if you can, please do so. And if you can't, transfer the patient somewhere where they can. And if it's not fixable, consider a total hip perhaps, or consider non-operative care, let it heal, and then a total hip later. Thanks very much.